This recording will continue Chapter 35, Upper Respiratory Disorders. First, we're going to talk about antitussives and expectorants. So, antitussives act on the control center and the medulla to suppress cough reflux. So, antitussives are anti-cough medications or cough suppressants. Expectorants loosen bronchial secretions so they can be eliminated by coughing. So expectorants help to break up that mucus so it makes it easier for the patient to cough up the mucus and be able to spit it out. Now, the textbook doesn't do a great job of classifying these medications that you need to know. So for studying purposes, for purpose of exam, you want to focus on this PowerPoint in this lecture. So in terms of classification, dextromethorphan is your prototype non-opioid antitussive, right? So dextromethorphan is your prototype non-opioid antitussive or cough suppressant. Benzonatate is also another non-opioid antitussive that I want you to be familiar with because you'll see it a lot in the clinical setting. Its brand name is Tessalon Pearls, so you'll hear that one. Codeine is an opioid antitussive. And then guaifenesin is an expectorant. So guaifenesin, if you think of an expectorant, again, breaking up the mucus so the patient can spit it out, can you think of what brand name you might see guaifenesin under? If you said Mucinex, that's what we're talking about there. So please, when you're studying, use that chart as a guide as to the medications that you need to know that are antitussives and expectorants and what classifications they fall under. So in terms of antitussives, again, they act on the cough control center in the medulla to suppress cough reflux. The cough is a naturally protective way to clear the airway of secretions or any collected matter. A sore throat may cause coughing that increases throat irritation. If a cough is non-productive and irritating, an antitussive may be taken. So in your textbook, it talks about if it's non-productive and irritating. A lot of times, a patient with a productive cough, they might not be prescribed an antitussive because the doctor actually wants them to be able to cough and bring up that mucus that's in their airways. Antitussives, though, you can see frequently with those non-productive, irritating coughs. Antitussives can either be non-opioid or opioid, or they can be used in combination. Again, your prototype antitussive that we're going to talk about is dextromethorphan hydrobromide. Dextromethorphan is an antitussive, so it's a cough suppressant that results in the patient coughing less frequently. Dextromethorphan should be used with caution in patients with asthma, bronchitis, heart failure, and tobacco smoking. A life-threatening adverse reaction of dextromethorphan is respiratory depression. So if we go back to the chart that you're going to study for exam purposes, dextromethorphan, non-opioid antitussive, so non-opioid cough suppressant. Benzonatate, non-opioid antitussive, right? Codeine is the one that's a little different. It's an opioid antitussive. So codeine can be in medications to help suppress coughing. And it's important that you know that and understand that because normally you think codeine and you think of pain relief or an analgesic, but it can be used for its antitussive properties also. So it's important that you understand that and know that, so when you have a patient who's coughing and you go to give them a medication with codeine and they say, well, I don't have any pain, that you are able to explain to your patient, no, I'm not giving you this for its pain relieving properties, but for its cough suppressant properties. And then again, your prototype expectorant is guaifenesin. Get you over here. Again, expectorants work by loosening bronchial secretions, by reducing surface tension of the secretions, and allows elimination by coughing. Guaifenesin is the most common expectorant that you're going to see in products. It's important to know that hydration is the best natural expectorant. So again, when your patients are ill and they're having this thick, nasty, productive cough, one thing you can do is push fluids if it's not contraindicated for any other reasons. You want to encourage your patient to increase the amount of fluids that they're drinking because that alone will help thin out those secretions and make it easier for the patient to cough them up. When taking an expectorant, patients should increase fluid intake to at least 8 glasses per day to help loosen mucus. Next, we're going to move to the purple nursing process box for the common cold. Go ahead and pause the video and look it over and see what important information you can pull out there. All right, in terms of assessment, we want to get a medical history, find out if there's a history of hypertension, get a drug history because of drug-to-drug interactions, dextromethorphan given with MAOIs, narcotics, sedative, hypnotics, barbiturates, antidepressants, and alcohol may increase toxicity. We want to get baseline vitals and assess cardiac and respiratory status baseline. Nursing diagnosis, obviously airways listed first in your textbook. That's always your priority. Airway clearance being a problem, ineffective related to nasal congestion. It also lists fluid volume, sleep deprivation, fatigue, and infection. Planning, or our goal here, is that the patient's cough will be eliminated and diminished. They talk a little bit about the decongestants and whatnot also in this purple box. So also we'd want to see a decrease in nasal congestion. Patient will be free from secondary bacterial infection. Under interventions, monitor vital signs. Blood pressure can become elevated when a decongestant is taken, and dysrhythmia can also occur. Observe the color of bronchial secretions. Yellow or green mucus are indicative of bronchial infection. Your textbook talks a lot about the color of the mucus being indicative, like a yellow-green mucus being indicative of bacterial infection, but that isn't always a bacterial infection. So what current research is saying is that viral infections can also lead to that discoloration. So I would just say in general that yellow-green mucus is indicative of an infection. Warn patients that coating preparations for cough suppression can lead to tolerance and physical dependence. In terms of teaching, tell the patient that hypotension and hyperpyrexia may occur when dextromethorphan is taken with MAOIs. Teach patients about proper use of nasal sprays and proper use of puff or squeeze products, again with nasal decongestants. We want to teach our patients to use them for a max of 3 days. So after 3 days, they're at increased risk for rebound nasal congestion. Advise patients to read labels of over-the-counter drugs and to check with healthcare provider before taking cold remedies. This is especially important when taking other drugs or when a patient has major health problems such as hypertension or hyperthyroidism. Also, acetaminophen may be in many products promoting an overdose. Remember that the common cold is a viral infection and antibiotics are not helpful in treating viral infections. However, they may be prescribed if a secondary infection occurs. Encourage older patients with heart disease, asthma, emphysema, diabetes mellitus, or hypertension to contact the healthcare provider concerning the selection of drugs, including over-the-counter drugs. Direct patients not to drive during initial use of cold remedy containing an antihistamine because drowsiness is common. It is important to tell patients to maintain adequate fluid intake because fluids help to liquefy bronchial secretions to ease elimination with coughing.